Okay, Sachin, today's episode, we're going to chat about a really exciting topic, MBS item numbers in general practice in Australia.
Welcome to the podcast by Scale My Clinic, founded by Doctors Todd Cameron and Sachin Patel, who are on a mission to help every general practice owner achieve his or her dream. The Scale My Clinic podcast is designed to leave listeners with insights and understanding gained by real lived experience that will help general practice owners create impact, get their time back, and enjoy increased revenue. Join Todd and Sachin every week as they share their stories on the Scale My Clinic podcast.
Now, this might not sound exciting, but it is a cause of much angst in general practice in Australia. And it is also a reason that a lot of people end up in strife, not knowing the rules around some of these item numbers. So I think it's a really useful thing to unpack. So we're going to do a bit of an overview today. And we're also going to remind everybody that these descriptors are dynamic and the item numbers are dynamic. So, what we're here today is about the principles, and you need to make sure you go and read up-to-date information yourselves. First up, Sachin, let's kick it off with something easy like the attendance item numbers. And before I get your comment, what I'm going to do is just give you the breakdown based on the Australian government data as of today. The attendance item numbers, the portion that are level Bs, 77% of all of the item number used for this is the level B. So it's the level B or get out pretty well. And then level Cs, people might think they do, relatively frequency, but Australia-wide, it's 15% of attendance items. A level A, I'm not sure why people would ever use a level A, but let's pretend they do. 3.7%, maybe that's the Fluvax clinics. And then the level D, 1.8%. So bugger all as level Ds. And on the back of the level D percentage, we know that there are certain people lobbying for level E's in the community. So if a level D is 1.8% of the total number of attendance item numbers, what do you reckon a level E will be?
So let's just knock that one out of the park first. Why are we focusing on a level E when it's going to be obviously less than 1% of consultations that are greater than 60 minutes? Here's an example of how we focus on the wrong thing, completely the wrong thing. We need to focus where the activity is, and that activity is obviously the vast majority, 92% of consults are level B and C. If you were going to advocate for any change anywhere that's meaningful and impactful on patients and the clinicians that serve them, is going to be in that body, the level B and C. That's where the effort needs to be applied, because that's where there's the greatest benefit to be had for all. So that's the first thing to say. I think it speaks to the level B. Over 3/4 of consults are level B. Probably tells me a couple of things. One is that there are other item numbers that people are not using. That we know for sure. And the incentive, we know the way things are stacked up, could be seen to just push through level Bs. Now that might seem, sensible. People might be used to working like that. The reality is, just through a series of level Bs, it can be pretty draining on the clinician, and probably not as impactful as we might want for those that we're looking after. And there's probably different ways to make sure we're using all the item numbers that are available in the right way to deliver the best care possible. One thing we commonly come across, and we'll talk about billing types, I'm sure, today, but there are some private billing practices where people just stick to a level B because it's simple. Yeah, and I'll just do that. And I'm doing everything, because I'm looking after them comprehensively, but I'm just going to bill a level B. Yeah, I'd always question and explore myself to see, is that true? I think maybe certainly when we've explored in certain situations that hasn't been true. I think I'm doing everything for the patient, but actually maybe I'm not. It's worth exploring.
Absolutely. I think, one thing that is healthy is to maintain skepticism about your own ideas as well as everybody else's. And as you say, with the level B being the foundation of attendance item numbers, it does mean that people need to spend time optimizing exactly what they do in a level B consult. If that's the most common job you get to do, then working out how to completely nail that and maximize impact in that time is going to be really integral to how well you succeed as a clinician in terms of impact, time, and your financial reward at a clinician level, but also at a practice level, because this is the bit that you need to get really, really good at, because it is the bread and butter of what we do. Let's chat a bit about some of the other stuff, Sachin. Have you got another group that you'd like to start with? There's a few other groups out there that get used pretty well also. Which group would you like to start with?
Yeah, so we'll probably start with chronic disease.
Mm-hmm.
So chronic disease items are easily, they've grown, the usage of those has grown substantially over recent years, of course. And the policymakers have been trying to make shifts to capitation or pseudo-capitation, and there's been trials like with the healthcare homes trial. So there is a push towards that. With chronic disease items, I think these still would remain underused in many clinics for sure. Or when they are used, there'd be some issues around compliance, I'm sure, as well. I think probably worth stating at this point, the descriptor is not the description of the item number. Okay, so the descriptor is not the description, because the actual full description of what needs to be done to be compliant with a Medicare item number is spread over 2 or 3 areas.
Yeah, you wouldn't want to make it simple. I mean, your objective, if you're at Medicare or the MBS, is to trick people, right, and obfuscate. So let's spread it or hide it in a few different locations, and then maybe they won't get it all together.
Exactly right. So you have, and this is with any item number. Anyone who's doing any billing related to Medicare rebatable services needs to be really clear on this. All right. So you've got your descriptor, which is when you go to mbs.gov.au and you type in the item number and you read it, that's the descriptor. So that's where the description should be. And a third of it is there. Then there's at the bottom links to the explanatory notes. So when you go to those explanatory notes, some more of the description is there. And it's not instead of or a repetition of what's in the descriptor. It's actually additional stuff. And then beyond that, there's the actual legislation where some other bits get buried. And so...
Or silent changes that occur.
Yeah, and subtle changes can happen there as well. So in the modern environment, you do have to get really familiar with all of that and don't assume that you've met all the requirements. Certainly, in Project X with our members, we give all of the audit sheets so that we've consolidated all of that. But beyond that, it's no good just having those audit sheets, right? You need to actually have discussions as a team to make sure that all of the clinicians understand their obligations and requirements. Because the reality is, if we ever fall foul of Medicare requirements, and over the coming years, I'm sure they will be looking to recoup money after the what's happened in the pandemic. We need to make sure and feel that we are safe and clear around financial risk, because with the shared debt recovery scheme, owners are much more at risk of increased Medicare compliance activity. And it actually, if I've charged a 35% service fee or a 40% service fee, that money isn't magically sitting in my bank account, is it? It's the majority of that has been spent on delivering services.
Yep. Staff, rent, you name it.
Exactly. All the other costs. And then having a bill come, as well as the destabilizing effects of that to the clinicians, it's pretty, it's an area to be mindful of compliance activity, very mindful of. So with chronic disease, the thing I like about those item numbers is there is no time element. So more efficient, and the more you can nail your processes, similar to what you were talking about, Todd, with level Bs. If you can really nail that whole process well, get the compliance right, but also the patient experience and the impact we're having, then you're not tied to time. Right?
No, that's not for want of the Medicare guys trying. I happened to sit in on at a conference where the Medicare guys were invited on stage. It was pretty unimpressive performance, but amongst the things that they floated was time-based chronic disease, and that there wouldn't be a problem with that, would there? Was pretty well the way that was asked. So, again, that in the end that the idea here is, because this should be about team-based care, and it should be visits where there is a focus on prevention, and unlocking the health goals that patients have. So when it's done really well, I think it's a brilliant part of healthcare, because just not putting fires out. It's going to be, and I won't say the only time, because a lot of clinicians do this anyway, but if you're doing it anyway and you're not using the chronic disease item numbers, well, then more fool you. You're doing the work, but you're not going and charging for it. It would be like being a tradie and just doing some extra bonus work for no particular reason that nobody asked you to do. So I think it is important that we recognise that there's value when you have organised planned care that is purely about the patient's focus and their needs in coming months and years for their health, and how we can help them achieve those objectives. And then that to my mind sets the strategy, and then the visits in between are tactical visits that we do anyway. But tactics without strategy is really having no rudder on your boat. And so the chronic disease visits do allow you to do that, and do that well. The process for this is not easy, is it, such? And it is simple, but it isn't easy. There's a lot that goes into getting this right. And when we have doctors when we have clinics that need to work on this, what do you estimate is the amount of time for them to get this kind of part of the practice working well? How long does it take to upgrade your CDM clinic?
Yeah, I think, if you're doing it yourself, it could be a year plus. With the resources that, members that have done it successfully in Project X, you're looking at somewhere between the 3, 6, 9 months, depending on where they're starting from. I think you're mentioning the time-based thing is interesting, because again, there are members of our profession who want to introduce time-based provision around chronic disease, which is again, penalizing people for doing it incredibly well and efficiently. It drives inefficiency. We've got to think about, how can I make this the best experience for all, and have the highest impact, rather than how can I make it take more time. It doesn't make sense.
Not at all.
So yeah, I'd probably say 3 to 9 months, somewhere in that window, depending on where you're starting at. But very powerful when you can do it. One of the most common questions we get asked, Todd, is, what proportion of my patients should have chronic disease?
Yeah.
How many chronic disease plans should I do? All of those type of questions. I think the best guide we can give that the government has shown is in the healthcare homes trial. They repeatedly talked about something like 21% of people they've calculated would be eligible for some type of chronic disease activity and care. Now, maybe I'm skeptical, but normally they have a history of underestimating these things. So I'd expect that's a reasonable starting point, and based on the demographics and the location and the practice profile and clinicians profile, you may vary at 10 or 15% above or below that. May go from maybe a window between 6, 7, 8% up to 30, 35, 40.
And remember, that's not revenue. That's the portion of patients.
Yeah.
So when you bring it back to a revenue number, it would be substantially higher than that, 21% as well. But yeah, as you say, the federal government kind of put a stake in the ground with that Australia-wide, and then the variation in the socioeconomic status mostly of communities will determine exactly what's going on there. And the problem here is you hear a lot of people in groups talking about ratios that you should adhere to, but the truth is it just has to be compliant, right? Because when they come knocking on your door, it's not about whether you did it or not. We just want to be really clear on that. So it can be really offensive when somebody's knocking your door and saying, I want money back for this. You say, yeah, but I did the work. So yeah, you did the work, but this little piece. And embedded in almost every high value item number is a couple of hand grenades that are intentionally placed there by the MBS, by our federal government, just for the purpose of reclaiming monies. So, almost all of them, right, Sachin? And you and I have observed this. It's probably worth sharing an example or two of where these kind of things play out, and they're taken pretty badly by clinicians, of course.
Oh, 100%. So there are specific lines in the descriptors where if that isn't met, they literally come with with a template looking for that one line. If it's not there, give me the money back. They don't care that you did it. They don't care how much evidence, not interested. It's purely a tick box exercise, this sort of activity. They're just not interested in whether you did it or not. All they're interested in, did you write it down?
And can I get the money back?
Exactly.
That's the main focus.
Absolutely. And so maybe a story, I'll share with you. There's one person that I've seen where with the item 732, the one of the lines is evidence that you've collaborated with members of the team care arrangement. That's one of the lines when it's a review of a TCA, item 732. And this person was actually being audited for 731, a different item number. But the auditor used the criteria for 732 because it's one of the most common criteria they trip people up with. So they were on autopilot and they just came along and said, all of your 731s are wrong because you've got no evidence of collaboration with two other providers. And so this person had to go through quite a lot of pain and argument. And it so turned out that the auditors just spent their time recently auditing lots of people with 732s. And so all they were doing is looking for that one line because they were in a bit of a habit. Anyway, a few months later, the auditor was sacked and that audit was cancelled for that item number because it was wrong.
Yeah.
This is the type of thing, it's just people who have no medical knowledge, have, look for these 7 or 8 things. And once they've picked one that they find people fall over on, that's all they're looking for, whether the other's there or not.
It's just shooting fish in a barrel for them. They have no context about the complexity of a consult, let alone having to adhere to MBS. And it's really stunning that because the MBS is the foundation of everything we do, there is no tool that allows you to confirm that you've done certain things along the way. Only the text that you enter in your notes. You can't verify, there's nothing. It's not embedded in software. It is rather unusual that we face these circumstances. And then increased activity, my favorite activity and I use a sarcastic tone there, from the MBS is just the jawboning they do, right? So they send all these letters now, voluntary acknowledgements where you're meant to repay funds or demonstrate why you didn't speed, why you didn't do something wrong. Imagine the police sending you letters saying, we think you've sped such, and would you be okay just paying us some money? If not, just prove how you haven't sped. That would be fine. That's pretty well how it works. Even worse, if it was the MBS that was running the speed limits, they'd take all the signs away as well, because that would make it much closer to fair and tilt it towards their side. Let's not get on a rant about the Medicare and the MBS people. We've talked about chronic disease management, and we know that co-billing was removed from that a while ago. Maybe that would be a reasonable transition into the mental health item numbers. And let's begin with a little bit of conversation around co-billing, because again, this got people into a fair bit of trouble 18 months ago. And it's really interesting how the MBS never sends something and says, oh, this is a warning, we've noticed this, we're just going to keep an eye on things. The first letter is always, we think you owe us money, tell us why you don't. The most recent one, I said no ranting, and I am going to rant. The most recent one was really annoyed me, was they letters to people in Melbourne that conducted telehealth consults with people that hadn't had physical consults in the 12 months prior. They could easily have removed the dates that they knew Melbourne was in lockdown. They didn't do that. They just said, we think you owe us all this money, prove why you don't. And just really bad form in the middle of another lockdown, actually, that they did that. So go figure. You know, as we've talked about, it's not about providing care at all. It's about them just having a budget for what money they can grab back. When they grab it back, they psychologically alter the enthusiasm of not only that doctor, but their close network of friends and anybody they speak to, because people are quite traumatized by this stuff. They feel really unfairly done, unjustly treated. But as I said, I broke my own promise there about ranting. I apologize. Co-billing. Let's talk about that.
Cheers,
and
bud.
mental health item numbers.
Yeah, absolutely. They rely on the conscience of the clinician, and that's where things, you know, we feel guilty even when we haven't done anything as clinicians. Just getting a letter or a notice of any sort, it's like when there's blue light behind you, your heart starts, you know, palpitating. It's the same thing. Someone sent me a letter, I must have done something wrong. Now, in terms of the mental health items, you've got time-based and non-time-based. The majority are time-based. So there's mental health consultations, there's mental health plans. Those are time-based, you know, and we're not going to go through them in detail here because people do need to go and read and understand for themselves. But those are time-based. It's pretty clear. The main thing to be mindful of is in a typical scenario is around when we might be seeing someone for something physical, and then a mental health issue may crop up. And so it's not unusual for us to then, as a clinician, do a safety netting and then bring them back to a subsequent consultation. And then we may only bill, they may not have accrued enough time at that consultation to actually bill for both services that you've actually given that day. So if you're not able to, you can quarantine that time that was spent on mental health and add it to a subsequent follow-up for mental health plan, not mental health consultation, but for mental health plan later, and add that time to the secondary consultation, as long as you haven't billed it the first time.
Right, so you're saying that if I see somebody and say the total consultation length is 18 minutes, and you know they came in and we talked about their gout for 7 minutes, and they said, by the way, you know, and that became a mental health consult that met the criteria, and we spent the next 11 minutes on that. What you're saying is I would have billed a level B, and so that wouldn't change based on the normal billing rules. But the 11 minutes that I invested in the mental health consult, provided I document that appropriately in those first lot of notes, that becomes a credit for the next visit. So if I wanted to bill a 20-minute minimum mental health consult, whatever item number that was, I would only have to do another 9 minutes before I got to that point. Okay, that's really useful, and I think not widely understood by people. So there's kind of a jackpot that you can roll over the time that you spend on a mental health consult from one visit to the next. Awesome. What other golden nuggets do you have, Sachin, for co-billing and mental health item numbers?
Absolutely. So, you know, as when there was the furore around co-billing, there are certain specific situations. So when someone comes with a physical problem and they unveil themselves to have a mental health issue as well, which is the most common scenario, then you are allowed to bill both together, as long as you meet the requirements for documenting appropriately. And those are laid out. You can look those up. It's freely available. But when it's the other way, where they come with a mental health issue and then reveal a physical problem that they need assistance with, you can only do that when it's immediately necessary to manage that physical issue. And so the notes have to clearly address that. When there was the issue around co-billing and mental health last year, they didn't make that clear.
Right.
The people immediately started to panic, of course. So people started to panic. So the order in which the problems are addressed is really important, because if it's physical, then mental health, that's clearly not an issue in what they've given us in terms of descriptor, explanatory notes, legislation. When it's the other way around, you do have to have it clearly written. And then when you're billing more than one item number, there's also specific requirements around note keeping, and those are available online. So it's important to make ourselves clearly educated about what those requirements are. Then, separate to this, Todd, the other two main things where people, fall down or aren't aware. One is with when sort of co-billing and a mix of private and bulk billing.
Yes.
So you can privately bill a level B and bulk bill a mental health consult. That's completely doable. Again,
it's called split billing, right?
Absolutely, split billing. And if you refer to Medicare explanatory notes, the first 40 or general notes of the book, it explains how you can do that and what circumstances. But that's legit. The other common one is around mental health plan reviews. So quite often people go to the GP, get their mental health plan, and then that's it. They're in the psychologist's world, and it's finished. Their problem's resolved or whatever, and it's never.
You get a letter when they need to unlock future visits, right?
Absolutely. That's the only time you hear back sometimes. So again, when you look at the descriptors, the intention is for a review to be done 4 weeks after the plan. That's an intention. So if that hasn't been done, it should be done. And then there needs to be a gap between that and the next one of at least 3 months. Now, the beauty of a mental health plan review at the time we're recording this is that there's no requirement around time for it. So it's something that is being missed. It's clearly stated that it should be being done in the descriptor or description, and where in the 3 places that is. And so it's an opportunity to review the mental health, and from a clinician's business perspective, also make sure that they've been able to avail themselves of all the right item numbers for that patient. So there are probably other areas that are easily missed. And of course, that can be co-billed, because that can be done opportunistically as well.
One interesting thing with this, Jess, actually, I've heard the federal government use the lack of reviews in mental health and care planning as rationale that the item numbers are not being effectively used, and that doctors therefore are gaming it by doing them, when actually the reverse is true. Doctors are intimidated so much by the MBS that they actually try and avoid using these item numbers, because they know that they come after people that don't meet the compliance standards. So rather than go and learn the rules of the game, the doctors think, I just won't play the game unless I really have to. So in order for them to get access to allied health or other health practitioners, they'll trigger a care plan appropriately often. Same thing with mental health, because it'll get the patient into the psychology ecosystem. And then they don't use the item numbers again, because they just think, I don't want somebody writing me letters, and I don't want this hassle. So rather than avoiding using them appropriately, we strongly recommend that, just like if you are, you're going to coach kids how to play soccer, you should read the rule book. If you're going to play general practice, you need to read the rule book. And this is one rule book that, there's just no two ways around it. You have to get in there and know the rules. The number of times I hear people talk about things as if it's knowledge, when they've never actually had first-person evidence of this. I just find it extraordinary where people talk about something as if it's factual, and the real question is, well, how do you know that? Why do you believe that to be true? Because so many of these things is manifestly untrue. It really is ridiculous. And if you think about a doctor that conducted general practice over, the useful lifespan of a GP could be 40 years, 50 years easily. Imagine if you just go into that 50-year block and you just don't really ever completely know the rules of the game, which is pretty common, right? Like these are not unusual things. What would you estimate that person over their lifetime might have lost? Or missed out on, maybe, is better.
Yeah. So let's just make easy numbers. Let's just say, 100,000 billing a year at a minimum for a full-timer at a minimum. So let's just go with that. So 100,000 a year. How many years did you say?
40 years.
Right. So 40 years. So in my mind, that would be 4 million of billings.
Yeah.
And if they're retaining 60% of that, right? So 4 million times 60%, 2.4 mil, right? And then take away tax. Okay, so take off 40% tax, which is roughly a million. So that's 1.5 million cold hard cash. And then if they'd invested that or put that to work somewhere over that period of time, maybe that would grow to at least triple.
Yep.
1.5. So that's what, 4.5, 5 mil ballpark over the course of a career. Yep. Something like that.
Maybe a lot more depending on what you put it in. So quite fascinating, isn't it? That there's two sort of different types. There's ignorance in that you just don't know, and then there's willful ignorance where I know I don't know and I don't want to know, which I hear commonly enough, and I just find stunning. I think it's amazing that you're proud of being stupid, but there you go. Some people do seem to like that, and so it is really important to be good at this, because it's not just about the money. This is about the breadth of care that you're offering your patients as well. These item numbers exist for a reason, to provide types of care that have been determined to be gold standard. Now you might not agree that they are in the way that they are worded, but the reality is those are the rules. So if you choose not to use them and not to give your patients access to the resources that those item numbers trigger, then again, I would suggest that your patient cohort is likely missing out as well, and you're missing out on an opportunity to impact your community in a much more substantial way. So these are important things. People do need to know the rules. They do need to use them. Now, you have a beautiful triangle that you use when it comes to the MBS section. So I might get you to finish up with describing that, and then we'll close out this episode.
Absolutely. One thing I'll just say, on backing on to what you just said before I share this triangle, Todd, is the government make their funding decisions. I think anyone in our industry will be in this part of the health system would be very clear that primary care in particular has been really disadvantaged over the last decade or more with policy.
Right? Yeah,
I think no doubt. The reality is, the only way they will know the work that is done in primary care is if it is appropriately billed for. And that the only data they really have around that is what item numbers are used. We could send advocacy groups to talk to them till we're blue in the face, till they're blue in the face, till the next government's in power. No one gives a stuff. The only thing they care about is the numbers they look at. And the only numbers they look at are the things that we do. And the only records of that activity is what is being billed and being done on the shop floor. So for those that think, I'm just not going to do this, you're giving the government a license and a pathway to cut the cloth of general practice even further, to really cut your lunch. Just be clear of that and have that conversation as a team with everyone in our business, because the reality is it's just going to make it less sustainable, because all their decisions will be to remove funding because you're not doing this and you're not doing that and you're not using this and you're not using that, so you can't be doing it. Everything needs to be recorded. If you're not interested in the items for any other reason, if you're interested in the profession and the profession's well-being and safety and sustainability into the long term, you just need to let that sink in. Now, the triangle is pretty simple. When people are approaching the business side of this, often they're straight away thinking, what can I build? What can I do? That's the first thing. Actually, nowadays, what we advocate is a 3-step process. First of all, compliance. We need to lock down compliance. That's the base of our triangle. The reason for that is that with the Shared Debt Recovery Scheme and increased Medicare compliance activity, if we don't have that base of the triangle in place, then any money we put inside that triangle will just fall out the bottom. So compliance first, then next is identify. So we need to identify the opportunities, and there's a whole variety of ways to do that. There's various tools, there's various functions within your practice software, but that's identifying opportunities. Once you've got compliance and you've been able to identify the opportunities, then the part that makes up the triangle is implementing the actions that you need to provide the various services and avail yourself of the revenue opportunities that are there. If you've got all three of those locked in, then in the middle of that triangle is where the money sits, and it's safe in there. So that's the way I would think about it, Tom.
I like it. Comply, identify, apply. That sounds like a good way to end this episode. And remember, as with any episode, scalers, I want you to think about what's been most useful for you today in what's been discussed, and what is one thing that you'll take out of this and act upon. And I hope one of them is to make sure that you understand the rules of the item numbers you use. And for anybody that's listening that is outside of the general practice space, same rules apply. Make sure you know the rules. And, increasingly there is heat coming on to non-GP areas of the healthcare workforce. And so expect more attention and more jawboning and more letters, more activity, of course. And on that note, we'll bid you farewell. See you in the next episode. Bye.
Bye-bye.
Thanks for tuning into the Scale My Clinic podcast with Todd and Seshin and the team. For more information and to get the resources mentioned in this podcast, visit www.scalemyclinic.com.